Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. Hello, everyone, and welcome to Spark Live. I'm Doug Maynard, Associate Director at Children's Healthcare Canada. And just a quick reminder, maybe one last time as we head into the Christmas break, just a quick reminder for those of you that have been participating in our webinars that were formerly called CAFC Presents, you are still in the right place. Back in our conference in October, we did introduce the new name of our organization, Children's Healthcare Canada, and our knowledge mobilization program is now called Spark. With our intent being to curate and convene and showcase excellence from across the child and youth healthcare community to spark conversations, ideas, and action. So since we are live, I do want to remind everyone you do have the opportunity to type in questions into the question box at any time that you think of a question. Don't feel you need to wait until the end of the presentation. Just type them in as you think of them. And also feel free to share your thoughts on Twitter and be sure to tag us at Child Health Can. All right, so today we are talking about neonatal telehealth, improving care for critically ill neonates in rural Alberta. And as I mentioned, our webinar series is about showcasing excellence in children's healthcare, and this work certainly fits that bill, as it was one of our award winners at our 2018 conference in Edmonton. It won the award for Best Poster in the Demonstration Project category. So it's a great pleasure to be able to share this work with our audience. So with that, it's my pleasure to introduce today's speakers. Today we have with us Dr. Jennifer Toy, who is a neonatologist in Edmonton, Alberta at the Stollery Children's Hospital, and she's the medical lead for the Neonatal Transport Team at Stollery. We also have Lori Schick, who is a registered nurse, presently working as a clinical facilitator in virtual health at Alberta Health Services in Edmonton. She was previously in the neonatal intensive care unit at Stollery Children's Hospital. We have Maureen Wass, who is an analyst with the virtual health team at Alberta Health Services, supporting the evaluation of virtual care initiatives in Alberta, focused initially on mental health and more recently on provincial virtual health activities. And we also have Natalie Mercy, who is a neonatal nurse practitioner at the NICU at the Stollery Children's Hospital and is the clinical lead for the Neonatal Transport Team there. All right, so it's my pleasure to hand the virtual podium over to the team in Edmonton. Over to you guys.
Thank you so much, and good day, everybody. Welcome. We're so happy to be here to be able to do this. I'm Natalie, and I will go first. Telehealth has certainly exploded in Edmonton and the surrounding area. So I just want to touch on the background of how it became so important to the NICU. And to do that, I'm talking a little bit about the Neonatal Transport Team. With our objectives, we're going to talk about the background. Thank you. With the Neonatal Transport Team, a little bit about telehealth and the newborn to NICU consultation process. Then we'll talk about the telemedicine technology and logistics, the telemedicine experience, and our lessons learned and future directions. To start, I'm just going to ask a poll question. As you can see here, we have a picture of our mini NICU on wheels with one of our most excellent transport nurses, Sherry, hauling on her back a pile of equipment, and there's more behind her. Our transport isolette, I say on wheels there, the Stork. We have three setups. This one is Stork number 3, it looks like, with our ventilator and our monitors and our pumps, and basically everything we need to go as far as we do to pick up sick, fragile babies. So our poll question is, how would you characterize your professional practice setting? A being, are you from a rural referral center? B, a regional hospital, referral and or a receiving site, C, a tertiary hospital, D, a community center, or E, other.
And most of the answers, it looks like they're in, so we'll close that off. And it looks like the majority are in the other category. But other than that, 20% are at tertiary hospitals, 13% are community service provider, and 13% also regional hospital, and 7% are rural referral centers.
Okay, perfect. That's fantastic, actually. So maybe a bit of information that's new for some of the people out there, which is wonderful. A bit of background about the transport team. Neonatology is actually, back in 1980 when the team was created, is still a relatively new subspecialty compared to other specialties such as cardiology, nephrology. And so it's still just around 40 years old. Back in the day, training for the transport nurses, when the idea came to focus, was done by the neonatologists. And at the time, an RN-RT model was chosen. And while there are different models across the country, the RN-RT model is still the system in Edmonton. Initially, we were one team based at the University of Alberta Hospital on the south side of Edmonton. And over time, this team has evolved into two teams. And currently, we have a need for three because of our huge number of transports. As well, the University Hospital years back started housing the Stollery Children's Hospital, the hospital within a hospital, and we went from there. As well, what happened I'm trying to think, about 10 years ago, the Stollery Children's Hospital NICU became a two-site NICU, in that we have NICU at the Royal Alexandra Hospital, which is the Stollery NICU RAH site, and the Stollery NICU at the University of Alberta Hospital, or David Schiff NICU. Who we are, we're a transport RN and a transport RT, with a medical lead being Dr. Toy, a transfer team coordinator, and an NP clinical lead. We have an NP manager and a patient care manager as well involved with the team. The biomedical engineer is a crucial part of the neonatal transport team. We have EMS, we have a telehealth lead with Lori. We have Stollery Critical Care Transport Team Leadership Group that is all critical care transport teams working together for the benefit of babies and children in our region. As well, we're part of work we're doing provincially with Calgary and then nationally with the Canadian Neonatal Transport Network. Where we go, the Stollery Children's NICU Transport, the neonatal transport team travels all through Alberta from Edmonton or Red Deer north. So Calgary takes care of southern Alberta, and the neonatal team in Edmonton covers Alberta north. As well, we also cover the parts of Northwest Territories, Nunavut, and as you can see, it's quite a big area. Our team actually covers roughly 1/3 of Canada's landmass. So big area that our team covers, which means long transport times. Over time, where we go has changed. Back in the day, we would cover a big part of northern BC as well as parts of the Yukon. Before we had a world-renowned cardiac program in Edmonton, we would travel to Toronto and Montreal to bring our cardiac babies for surgery there. So numerous trips every month, back and forth, dropping off babies and coming back later to picking them up. As well as neonatal transplant, heart transplant became more prominent, we would take our babies down to Loma Linda, California for transport. Where we go currently, just to give you a picture of what happens in the Edmonton zone, we have a Royal Alex Hospital that is the high-risk perinatal center that we have many births a year, almost 8,000. The U of A Hospital, where we're primarily housed, we only do critical cardiac deliveries at this site, so not too many deliveries. We don't actually have maternal health here at the University of Alberta Hospital. As well, we have two other major hospitals in Edmonton, the Grey Nuns and Misericordia Hospital, which deliver about 10,000 babies a year and have level 2 NICUs, which are a little bit less intensive NICUs, but where we bring a lot of our babies to. The Sturgeon Hospital in St. Albert, a bedroom city close to us, is opening an NICU in the fall of 2019. As well, we do, just to give you a sense of other areas, we have some major pediatric facilities in Alberta, Red Deer, Grand Prairie, and Fort McMurray. all these places actually have telehealth now capabilities. Not all of them have NICUs. As far as in the province, we have a lot of small centers that we go to and that deliver babies. So you can just see the list here. Most now are attached with telehealth. So a couple of years ago, this was a very different screen. All the Y's were N's, and it's exploded as the enthusiasm for this service has developed. There's still a few places that are pending, but even these places have 100 deliveries a year, so there are always some babies that have some issues and have some trouble. And the benefits of telehealth, I'm sure, will be coming to these sites soon as well. Our transport volume over the year has increased exponentially as well. 10 years ago, we had 500 transports a year. Before that, we were in the 300 number of transports a year. And last year, we had 779 trips. And this year alone, we've already surpassed that before December 1st. So our number of transports has definitely increased. As well, looking at the Canadian Neonatal Transport Network data, you can see that Toronto has the most transports of sick babies at 624. In Edmonton, we are actually second to that, and our numbers have creeped up to be closer to 500 actually than 400. So our busyness has increased, and the number of trips, like I say, our trips have increased, and then we've had some challenges as well. So our two-team staffing model is excellent, but we need more because of our increased number of trips. As always, every nursing team has staffing issues. One of our challenges has been that the University of Alberta Master of Nursing program and neonatal nurse practitioners has opened back up as of September. And so a number of our transport nurses have jumped into doing their master's degree to become nurse practitioners. So we've lost some members of the team. And as you can see, with increased transports are needed for 3 teams. The other problem we have in Edmonton is our times to getting out of our tertiary centers to go pick up babies. Emergency medical system services in Edmonton are very, very busy and stretched, and our times compared to the CNTN comparison are decreased. So the goal is to have all transport teams out within 30 minutes en route to pick up babies, and we only achieve that goal 30% of the time in Edmonton. So in order to deal with the fact that we have 1/3 of Canada's land mass to cover, some of our trips are 8, 10, 12 hours of travel time with refueling time if needed. If we don't get a Learjet or a jet of some sort, we have to go with a fixed wing plane. We need to stop and refuel. You can see how if you have a sick baby in high level who's going to be 8 hours before a transfer team gets there, and you have a physician up there who is taking care of a baby and the mom and covering a merge and needs some assistance, that the value of telemedicine is beyond words to even explain.
Great.
So Dr. Toy is going to take over.
Thanks, Natalie. It's Jennifer Toy. I'm going to just give you guys a little bit of background of our normal nursery to NICU telehealth consultation program. And we just wanted to get a little bit of a sense of our audience, of how many of you are currently using telehealth in your clinical practice.
Give everyone just another second or two. And just an interesting observation I made after that last poll, there was the other category was quite large. I was sort of surprised, but looking at some of the names that I recognize in our attendee list, I do recognize a number of family members who are from the Canadian Family Advisory Network or other organizations like that who put themselves, I'm sure, in the other category as opposed to representing a hospital. So I think that explains some of that interesting result in the categories last year. So, or in the last question, I mean. So. All right, so we'll close that off and share the results. And it looks like 67% are using telehealth in some form in their clinical practice, and 33% are not.
Okay, great. So the purpose of setting up this program for us, as Natalie's alluded to as well, is that we wanted to provide remote centers in our catchment area with access to a secure audiovisual connection with our tertiary NICU, for both urgent clinical management as well as for consultation and advice for the newborns and young infants that they are seeing in their practices. And we just have a few photos there that show our telehealth system in action. And we wanted to create a supportive environment for our healthcare providers, patients, families, and to promote wellness and teamwork. And this is just one of our neonatologists, Dr. Joint, assisting one of our referral sites with insertion of an umbilical line. So as a bit of background, we know that rural and regional facility resources and healthcare provider comfort level and experience with sick newborns can be variable, which may affect the team's ability to relay a thorough assessment by the telephone, as well with their comfort and ability in providing the required level of care that's recommended by the tertiary team. That can affect the degree of success in stabilizing the infant prior to our team arriving, as well as the number of babies that may end up being transported from their local communities that may have been able to stay at their local hospital, or for our team being dispatched and then evaluating the infant and resulting in them not being transported, and the resources related to that. So really what we wanted to do as our objective was take the virtual NICU team to the patient's bedside in the referral hospitals across Alberta. And we wanted to do this by optimizing the consultation process. So you all know the saying, a picture is worth 1,000 words, and I would argue a video is worth a million, because you just get such a better sense of the condition of the patient that the team is dealing with. It also helps to stabilize the patient prior to the transportation. And this just doesn't mean the ABCs, the critical things, but procedures such as establishing umbilical line access, mixing the antibiotic dosing. You can just facilitate that communication and the learning for the local sites more through the video conference system. We also wanted to support interdisciplinary team and standardize the quality of care. So no matter where you're born in Alberta, if you need support from the NICU team, that we can help standardize the care that patients and families are receiving. And then, of course, we wanted to increase family-centered care. So through the system, we've been able to enhance communication with the families. The families could be at their baby's bedside, on camera as well, talking directly to the team in Edmonton. This helps to prepare them for what to expect when their baby comes to our site, as well as in certain circumstances where it's appropriate for the baby to stay at a local hospital, to provide reassurance and guidance if that's the most appropriate step for their baby and what to expect for follow-up. We also wanted to build capacity for local management of common minor neonatal conditions that usually resolve with basic steps in neonatal management in those referral sites. And this is something we certainly need to work on how to evaluate. But from the feedback that we've received from individual local sites on a one-to-one basis, certainly sites are feeling much more confident. Our transport team members are going out to the sites and saying, the team was much more comfortable and confident in those steps, such as starting an IV, giving antibiotics. And then, of course, there's always the financial component. So just to give you an example, High Level is one of our most northern communities. It's 720 kilometers away from us in Edmonton. And really, fixed wing is the way that we would get there in a timely manner. So for a one-way flight, just for the fixed wing itself is just over $9,000. So that doesn't include the medical crew, the pilots, and our NICU team. So as you could see, being able to reduce even one transport from a center like this has huge cost implications. I'm going to hand the mic over to Lori Schick, our telehealth facilitator, and she's going to talk about the technology and logistics components.
Hi, I'm going to start first explaining a little bit about the equipment that we use in Alberta Health Services. The brand name is Polycom, and we have two sets on the screen here. This equipment you see on the right is what we call our clinical cart, and that is similar to that cart is what we install at the remote sites, and it is on wheels, so they're able to move it to different areas when it's needed. On the other side on your left, it's a desktop unit, and that's the unit that the NICU has, and it's located in the transport nurse's office, which is directly behind the main desk in the NICU, and it's a great place because it's close to where they take the phone calls, and there's privacy available for them. On the Polycom equipment, it has an HD camera and a great zoom on it. And those are really important factors when they're looking at the babies, so they're able to zoom in and look where they want to look. The other feature that is really valuable is this setup has a remote control camera. And so what that means is that when the physicians are at the Stollery and they want to visualize the baby, they can take over the movement of the camera at the remote site. So if whatever they want to zoom in on, they're able to. And that really helps the remote sites, because some of the sites are quite small, and to tie up somebody moving the camera wherever the physician would like to see just isn't really an option sometimes. So they're able to move it themselves. We do not use a wireless system at this time. Hopefully down the road, when the technology gets there, we'll sure be switching when we can. The connection's made through the Alberta Health Services encrypted internet, and technical support is available from the sites from Monday to Friday from 7 till 2100. And when you read that, I think the common thing we think is, whoa, what happens at night when babies are born? Honestly, it hasn't been a problem. The connections are through the Alberta Health Services network, and going from site to site, we have very few technical issues. For a privacy impact, there's no implications from an HIA point of view. And as I mentioned, the video conference connections are encrypted through the Alberta Health Services network. So on the screen now, I have our algorithm, and I realize that you can't see it. There is a copy available in the PDF of our presentation, and I'm not going to go through all the steps. I just wanted to go through the beginning of it. In Alberta, when a remote physician has a baby they'd like a consultation on, they call what we call RAPID. And RAPID is our provincial call center, and it stands for Referral, Access, Advice, Placement, Information, and Destination. So the first call for the physicians is to RAPID. And when we were developing the NICU program, we didn't want to change any processes that were already established. So we worked with RAPID to incorporate the video conference into the call, so we're not changing that initial call to RAPID. So the physicians still call RAPID, and they're put through to the neonatologist. And the RAPID has a list of all of the sites that have video conferencing equipment, and they just provide a reminder at the beginning of the call if the site has video conference equipment available. And then the physicians go on with the consultation, and they ultimately make the decision on whether the call is suitable as a video conference. When we started the program, we initially did a point-to-point call. In telehealth, a point-to-point call is one site calling the other site, so they pop up on the screen at the remote site, sort of like a phone call. And after we got to about 4 or 5 sites, it was like, whoa, this is a lot of numbers for the NICU to have a list of dialing. And we moved over to a virtual room setup. And a virtual room is a room that's created in cyberspace by the Alberta Health Services Bridge. And what it is, it kind of just sits there, and then when sites need to meet, they both dial into the virtual room to meet. And the benefits of it are that multiple sites can join without contacting the bridge. So normally if you're doing a video conference, and you have 2 sites and you think, well, we'd like to add a 3rd site, you contact the bridge and they add the site on or build the call for you. With the virtual room, that step isn't necessary. They can call in 24/7 without the bridge being involved as a person to set the call up. There's also one number for the connection. So what we're able to do is all of the sites, as well as the Stollery, dial the same number. So we put that number on the home screen. So basically the equipment is woken up, and when the home screen comes on, it says NICU virtual room, and they click a button to enter the room. The room also has an audio line available. So if our neonatologist wasn't able to get to video conference equipment, but the transport nurse at the Stollery was, the neonatologist can join the virtual room by the audio line. Of course, they wouldn't have video, but they would be able to listen to the call and have the transport nurse be the eyes. The only challenges with the virtual room, there are very few, and they can definitely be looked after with education, and that's how we look after them, is the length of the calls are difficult to predict. When we set up the virtual room, we thought, well, 2 hours should be pretty good. The calls won't be that long, and then it would automatically disconnect. And then we quickly learned that, no, that wasn't long enough because, as Natalie mentioned, the distance of the sites, and also if they're fogged in or anything, and the team can't mobilize as quickly as they'd like to, there's a delay. And so sometimes the calls are much longer than that. So with the education, we remind the sites that they need to disconnect when the call's done, because the call doesn't automatically disconnect when one side does. The other side remains in the room. The only other thing is that we do a lot of teaching with is a little bit of confusion when the site enters the room. And what we're learning is that the remote sites, they pretty well know when they want to do a video conference, and they're set up when they make that first call to Rapid, so that physicians discuss the baby, and then the remote sites all ready, they dial into the virtual room, but the neonatologist may not be. They may be in their office. They may not be by the video conference equipment. And so they may have to walk to the equipment. So there's a little bit of a delay of them joining the room. And I'm sure if it's a very sick baby, it seems a lot more than a couple minutes to the remote site. So again, we do a lot of teaching so they realize, yes, they are coming, but they may not be on the screen when you enter the room. About a year and a half ago, we started a new addition to the program, and the neonatologists have loaded a video conference program onto their laptops. So what this program does is it allows them to join the virtual room when they're off site. And this has been a great benefit for them because they don't have to be in the unit to do the video conference. And where it's especially great is if a site wants to do a video conference and the transport nurse is out, and then the neonatologist can connect directly from their laptop to the remote site to see the infant. And the picture on the screen sort of shows you with 3 sites. We have Grand Prairie with the overhead and Dr. Toy. And up in the corner, I'm actually at another town just outside of Edmonton taking the picture. So we have the 3 sites. And it's worked really great. The physicians love it. For implementation of the program, we started with, of course, site selection, and it's kind of evolved over the years how the selection goes. Initially, we started looking at the sites when we were deciding what sites we'd like to include with the number of deliveries per year and the pediatrician availability. So we started with the level 1 sites, which are your sites that don't have access to a pediatrician. And I'm not sure if it's the same in the other provinces, but in Alberta, a lot of the smaller remote sites have difficulty getting permanent physicians. So we have physicians out there who are on locums and not comfortable when an ill newborn they have one. And so those are the sites we started with. And of course, we got wonderful buy-in for being able to provide support for them. We do have some sites that were recommended by Quality Assurance Review. And it's just sites that they really felt would benefit having the ability to consult the NICU when they need it. Now, I'd say about in the last year and a half, the sites are starting to request it. They're talking to other sites and realizing what the program is, and they're now asking us to be part of the program. When we start with the sites, we identify the stakeholders. What we have learned is the best contacts at the remote site, some of them were actually cold calling to tell them about the program if they don't know, is the site director, educator, or labor and delivery manager are usually the first ones that we approach and explain the program to. And we let them take it to medicine. Medicine buy-in is crucial. The physicians have to be willing to use the video conference equipment to make the connection for support. And what Dr. Toy actually made a memo for us to provide to medicine, so we had something concrete. And the memo is very simple. It explains the program, but the 2 things that are emphasized in the memo that are very important for the remote sites to understand is that doing a video conference does not delay the process of the team mobilizing. As soon as the physician takes the call from Rapid, the transport nurse is on the call as well. She's listening. She's working in the background. And if the infant needs to be transported immediately, even though they're doing a video conference, that's definitely occurring. And the other point that's highlighted is that the program was not set up so the sites would keep the infants. It's totally understand they cannot keep the sites. They don't have the facilities and they don't have the staff, and the infants need to come. It's only to provide support until the transport team gets there or advice for a consultation. When we went with site assessments after we knew the site wanted to be part of the program, the first challenge was data ports. In Alberta, the remote sites, very few of them have data ports where we need them. We recommend the data ports be in each labor and delivery room, and a lot of the sites have what used to be a general nurseries, which is now a resuscitation room, and that is where we also like to have a data port. the operating room for any cases of fetal distress when they think they may need the team right from delivery to support a resuscitation, and in the emergency room. The emergency room we recommend for babies who may be discharged and have to come back and come through the emergency room, as well as on that cart. If it's used in the emergency room, we have our pediatric ICU virtual room on it, which is another program. And a lot of the sites we've buddied on with the Alberta Stroke Program, which is an adult program. And then when the site does their consultation through Rapid, they're able to choose which video conference they would like to do, which room they'd like to connect to. Another important factor was the equipment location. The equipment needed to be located a place where the staff could see it and be easily accessible and easy to use. And when our equipment is stored, it needs to be connected to a data port for remote updates. So those are all things in the site assessment that we would look at before installing the equipment. And for funding, all the remote sites are asked to look for donors or their foundation for funding. And then we have a discussion on how we're going to work the funding out prior to deployment of the equipment. When the equipment's dropped off, we do brief. It's usually the technical team that does a initial training, and we leave very simple documentation, infection control information, troubleshooting, and the technical support number. After that, within the next week or so, I set up teaching, and it's usually with the educator, and we do drop-in sessions for the staff for a day, and they'll come in and we'll practice dialing into the virtual room, and I teach them about the program and get them comfortable with the equipment. After that, we do, some of the sites like to do scheduled testing, which is in the beginning, we start with every week, say every Tuesday morning, they have a quiet time, and we'll do testing of the equipment and make a practice call. Other sites just prefer, they just ad hoc test and fire off an email, and we do a quick test, and we're reviewing new methods for testing because our goal is to provide ownership of the equipment for the team, so it's checked like a crash cart is checked in the morning and testing is done by them. The evaluation of the program has been a struggle to get evaluation forms. We started with a written form, and the remote sites, they do struggle with it, and it's totally understandable why they would. A lot of these sites are small, and the nurse is very busy looking after the baby until the transport team gets there, so there isn't much time for additional paperwork. And so often, they're off shift when the transport team comes or they go home. So I do a lot of chasing of evaluations, and I'm not too sure how you fix that. We went to an online form about a year and a half ago, and it has worked very well on the Stollery side, but the feedback from the remote sites was that they just don't have access to computers for the nurses to do the online. So right now we're doing a paper and an online format. And what we're asking is, on the evaluation, is the usefulness of the consultation in stabilization of the infant, the quality of the connection time, any barriers they found to using the technology, and the infant diagnosis and outcome. And the outcome is just where the infant was transferred to or where they stayed. And now Dr. Toy will take over on what our evaluation has taught us.
Yeah, so I did just change our name to the Nursery to NICU Telehealth Consultation, because as this program has grown, it's not just the level 1 sites that are involved, but level 2 sites as well in the program. And this is just a screenshot of what we did to engage our Stollery staff. We have a group of our neonatologists in the small screen there. And this is a well baby, but we just to show the resolution and how much you can zoom in on the infants. That was really important to get buy-in from our site, because you can actually zoom in and see how many vessels there are in the umbilical cord with the cameras that we have. So we started this program in 2014 and 15 with just 3 pilot sites in northern Alberta, and did demonstrate feasibility and success, and therefore operationalized it the following year and expanded additional 8 sites and had 24 consultations. And as Lori pointed out, it wasn't our intention to have patients stay at local communities with this program, but 40% of the consultations done in 2016 did end up not requiring transport. And then in 2017, we had an additional 13 sites, and then with the electronic call logs, we were able to have more analysis of the calls and the program. So over that period of time, we had a 50% increase in calls, and as you can see in the first column in that table, those numbers have been increasing over time. But we also saw an additional pattern that sites were starting to use it for callbacks. So the team would get on the call, assess the infant, and then make a plan to reconnect by video conference at a period down the line to reassess whether the infant was still appropriate to stay at the local hospital or if they did indeed need transport. And the other reason that sometimes 2 calls are done is for a more acute sick infant to reconnect and help to support the team at the referral sites until our team arrives. So just to give you a little bit of an idea of the numbers and the outcomes that we measured. So by far the majority of logs reported that it was successful and supported patient care. The one situation where it didn't was actually a technical issue, that the remote site wasn't able to join the virtual room. And so there was actually never a video connection established. The calls, as Laurie alluded to, are long. So on average, 24 minutes. So it's quite a bit longer than the usual telephone consultation, but I think that's part of the advantage of it, is that you get more time and can support the team better. And then we did look at the number of calls that are occurring after hours, so after 5 p.m., and that's about a third of the calls that we did through the telehealth system. So in 2017, we had a bit more of infants staying at their local sites, so about 46%. Advice was provided for local management. And then we had the majority of the rest being transported either to a level 3, which is our highest level of care, NICU, or to a level 2 NICU within our network, either within Edmonton or one of our regional sites, which is Red Deer and Grand Prairie. Just looking at why consultation is done when you know the neonatal population, respiratory distress makes sense to be the most common reason for consultation. The other category includes things mostly made up of sepsis. And then, of course, we have prematurity and some infants with hypoxic ischemic encephalopathy. And so I'm not going to read through the comments, but there also is an area in our report where clinicians are able to provide feedback about the process. And it was overwhelmingly in support of this program. So just the ability to see and support the resuscitations of infants, as well as to guide through procedures, has been very helpful. And so this is just our most recent map of where we're at. So we have 26 sites across northern and central Alberta, which we are able to connect to for a nursery to NICU consultation. And the yellow stars at the bottom just show Calgary's sites as well, because they've also started a similar program. So just in summary, we'll just go over what we've learned and where we hope to go. So stakeholder engagement is, of course, essential in establishing this. If you don't have the team at the referral site engaged, they're not going to use the equipment, and it's just going to sit there in a storage room. It's excellent if you can engage a site champion who really engages the rest of the local team, and making sure the storage cart's in a visible area. And then ensuring that the experience with telehealth is a positive one. And we know sites that have had good experiences tend to use the equipment more and more. And then, of course, making sure that it integrates into existing workflows. So that's why we've included into our call and consultation system that exists, so that we're not duplicating work and causing confusion, but making the workflow smooth. So our goals are to include all the referral sites within northern and central Alberta, and we have 7 more sites to go. 2 of those are just waiting for data ports, 2 are waiting for equipment, and 3 we're in the process of engaging. We want to increase the number of consultations completed by video conference. So if a site has telehealth, we really believe that that should be the go-to for those sites. we want to extend to include First Nations and Inuit health authorities within Northern Alberta. So these sites have telehealth equipment that is within the AHS network. So it's just working with those sites a bit more to establish that connection. And then also extension into Northwest Territories and Nunavut. So they also have an amazing telehealth system set up, but because the bridges are different, we need to get my IT colleagues, not me, to figure out how to make those two systems talk to each other. Because certainly those are some of the longest transports, and those are some of the infants that are waiting the longest before our team is able to go there. And there's also a lot of very remote sites in the territories, as we all know. We're continuing to work to enhance our evaluation and outcome data. As Lori was referring to, we want to get more feedback from the referral site so we can support them if there's any areas that's necessary. And we also want to enhance transport team communication. So our PICU team here has actually established a technology where they can use that real present desktop technology on the laptops that their team members take out to pick up infants. Therefore, regardless whether the site has telehealth or not, the transport team can call back by video conference to home base and get support from the physician at home base. And that's not just in the hospital, but in the back of the ambulance. If you can establish an internet connection there, then they can also have quick consultations by video. And then we are also working to engage our referral sites regarding program development for educational sessions and simulation. We've done several informal simulations, which have gone really well and been really well received from sites, not only for the support and comfort in using their telehealth equipment, but also to engage the tertiary sites' knowledge and expertise to build capacity at the referral sites. So I'm just going to finish off here with a quick little story, and then we'll open it up to questions. So the story is about a little baby boy that was born up in one of our regional sites in Grand Prairie, term baby, uncomplicated pregnancy. But the nurse noticed a rash at delivery, so called the pediatrician to come assess. And the pediatrician agreed this was unusual. There was blisters and skin breakdown. So they called our team at the Stollery, and we got on the video conference line, and our team, in collaboration with the pediatricians in Grand Prairie, was able to confirm this looked like a fragile skin condition that definitely needed to come to a tertiary site for more support and care. But they were also able to, through this video connection, advise the team in the referral site to avoid too many adhesives, because that increases the skin breakdown, how to put dressings on the skin lesions that were already there, and to put in an umbilical line, so to avoid the IV line. So our team goes up and gets the little baby, and then once they're happy, they bring the baby to one of our hospitals at the Royal Alexandra Hospital. And the baby's there for several weeks. They see the specialist, the dermatologist, they get a diagnosis. The good news is it has quite a good prognosis, but it does require a lot of pain management and dressing changes in the first several months of life. But it's hard for the family to be away from home. Baby's dad is in an SUV accident and needs to be in the hospital as well. Mom's torn between the two hospitals. Grandma's here to support, but it's also hard for her to be away from work and to be supportive. So with our teams in Edmonton and in our referral site, we talk, and we are able to get this baby back to the neonatal unit in the regional center. And we can send our wound care nurse with them to help support that. But as this baby still needs a lot of high-level care, we use telehealth to communicate back with the dermatologist to make sure that the pain management and that the wound care plans are still working for this family. And pretty soon this baby is ready to go home in their community. So that's the end of our presentation. This is our contact information if you guys have any specific questions you wanted to direct to us, but I think I'll leave it to Doug to see if there's any questions from the group.
All right. Thank you very much. Great presentation. A great story at the end. I mean, it really sort of, it helps people understand this is more than just about sort of resuscitation of premature babies or that sort of thing. Like it's about the full spectrum of care that you can help support at a distance. So that was a great example to end with. So we did have a question when you were talking about, you were showing the three individuals that were connected to, like showing how you can have a physician come in on their laptop with special software. There was some questions about that. So is that allow the physician to be anywhere, including, taking a call shift from home, for example, and being able to connect securely from a home network, like through it must be some sort of a VPN, I would assume, or something like that. Can you just, there's just some interest in learning a little bit more about what that experience is like for the physician and how that exactly works.
Yeah, so the program is loaded onto the physician's computer, so they don't need to be on a network internet. So they could be on most people use Wi-Fi now, so they can be on a Wi-Fi network. And then once they have that software on their computer, connect from any place, whether that's home or another site. Lori, I don't know if you want to add any more technical aspects of that.
And since it is into the virtual room, it is encrypted, so it is a secure connection as they enter the virtual room. And that's always our biggest concern, is for confidentiality, that it is a secure encrypted connection for them. Yeah.
Yeah, that's always, and we've done many presentations over the last number of years that are related to telehealth in some way, and that's always one of the concerns is the security issue, and I think people are slowly becoming more comfortable with that we've got that nailed, that we can actually secure these connections. The other thing I think we found previously in other presentations is I don't think people who have not participated in this kind of telehealth session understand how far the technology has come particularly in the level of resolution of these cameras and what you are able to see, the definition of the images that comes through, and your ability to see very small, fine detail. In some cases, the audio and in places that do remote breath sounds and heart sounds and that sort of thing. I think people are not, if you haven't participated in it, I don't think people realize how far the technology has come.
Well, actually, it's so effective that you could zoom in and see the 3 vessels in the baby's umbilical cord and actually guide the practitioner at the remote site as they insert a line into the proper vessel. There was another situation where the remote site was resuscitating a baby, having difficulty doing the intubation, and we're putting the breathing tube in. As well, they were doing compressions, and you could see that help them position the head so that they could have better access to view where to put the tube, as well able to correct the compression to breathing rate that they were doing for the baby. And there was another time where one of the physicians at our tertiary center was able to help the nurse put an IV in to the baby. I think it was baby was in the nursery, but they pulled an emerge nurse or someone that was very good at IVs, even though she wasn't used to doing babies, and just helped her as she slipped that in. So it's very effective for helping out the remote centers, that's for sure.
Mm-hmm. We did have a question come in from Jamie, who's asking, how did you ensure that the staff at the Stollery are using the telehealth? She says they're in a PICU environment and they're having trouble doing this, as their physicians specifically are very busy and they're finding it hard to incorporate telehealth into their regular workflow. Do you have any tips for that?
I agree that can certainly be a challenge, and we've been very fortunate that we've had great buy-in from our team here. As the picture I showed you, that did, I think, help as well. Just getting all the physicians together and showing them what an actual video looks like, so they have a better concept of what to expect. In addition, it's part of our similar workflow in that we would otherwise be on the telephone with this referral site. So it's just a matter of changing that concept of what type of connection is being made. And our equipment is also directly on the unit, where during the daytime the physician is, so it's easy to pull them into the room. Do you have any other comments on that, Lori?
No, and what the other thing is, like Dr. Toy said, if they use it once, it sells itself for additional video conferences. They just need that one experience where it really made a difference, and it really does sell itself.
And the rapid there's a prompt now in our process from Rapid to ask if we want to use telehealth, I think is how it works. We kind of just established that recently, but then there's the actual prompt from that, from the person on the phone who's connecting us with the referral site. And so it's a trigger to, okay, yes, actually, let's log in, let's sign into this virtual room. And like Lori said, or Jen said, it's literally around the desk is where our computer is set up.
I did have a couple questions when you were talking early on in the presentation about one of the objectives was to improve like family engagement of the family at a distance as well. Can you expand a little more about the kinds of scenarios that like you showed, I think it was a mom on the screen, like so you're actually putting the mom on the screen to talk with the physicians. Can you give us some scenarios of what exactly the kind of information that the parent was able to contribute? Or is it more just around providing the history and that sort of thing, or is there more to that interaction with the family member?
Yeah, I think you hit the nail on the head there. It's often adding to the history taking that we need for the baby, especially those babies that come in through a merge. We do transport infants up to 28 days of age here, 44 weeks corrected, so it's not all newborn. So certainly getting the parent who's side of the infant involved in that history taking is very valuable, as opposed to having someone on the phone and you're trying to relay information. And then I think just again, we had scenarios too where it was helpful to discuss with the parent what we felt the diagnosis was, and that there wasn't any why it was appropriate for babies to stay in local hospitals as well. I think that provides reassurance to families.
You talked about using sort of the next steps was around using the telehealth system for training and simulation and that sort of thing. Is there are you using it for when the baby returns back to their rural setting to sort of support the family and sort of further supporting them in being able to care for the baby who probably still has ongoing issues? Or
so we haven't done that with our NICU program, but that's something PICU is doing. When they take babies back, transport patients back to their community hospitals, they can have a teleconference prior to the transport, as well as having follow-up. So I think that's, there's potential for that as well, but it's not something we've explored personally yet.
And then for the infants, if there's any other specialties other than neonatology, they work with the other clinics within the Stollery and are able to do follow-up via video conference. And it works very well because the parents have been exposed to it. So they actually ask, is there any chance this could be by video conference to save them a trip to Edmonton? And quite often it can be.
Yeah, like the example I provided, dermatology uses telehealth quite a lot. So they were able to continue to be in contact with that family, not only while they were in hospital, then once they're discharged home as well. They do a lot of appointments via telehealth. And the pediatric surgery team also does a lot of, is a high user.
Interesting, yeah. So those do seem like two great applications, being so visual, dermatology and surgery around wound care and that sort of thing. That it seems like a great application for that. All right, so with that, I think we are pretty much out of questions. We don't have any more coming in here, so maybe we will. Maybe this is a good opportunity to wrap up. We only have a couple minutes left, but before we wrap up, maybe we'll just give the team and Dr. Toy. Maybe we can just get you to sort of coordinate to see who in the room wants to provide any last closing comments or key messages that you would like to leave the audience with before we wrap up.
Certainly, if anyone has any questions as they're starting to develop or use video telehealth more often, we're certainly open to questions and comments and any help that we can provide on our experiences. I know there's other provinces out there that cover grand areas of Canada's landmass. Without question, it's certainly, I think, saved babies' lives having this technology, as well as it's supported the staff that's left behind. As if the typical situation is a baby is born, something happens, there's a doctor there to help take care of the baby, but there's one doctor for a community of how much, and being pulled in many directions. So by the time the team can get there 8 hours later, 10 hours later, 12 hours later, depending sometimes on weather and mode of transport, you have nursing staff or LPNs that are with this fragile baby who are a little bit overwhelmed by, it's the only way to put it. There's many times when I was on the transport team that we'd have people waiting at the emerge doors, at the next door. They can't get the team fast enough into where this baby is. So to have that connection to advanced neonatal care has just been such a reassurance for the staff that I think it saved a lot of anxiety, actually, even in frontline staff. So it's NICU jumped on this opportunity right away. We kind of were early adopters and bought into it right away, and it's been I think a life's like, what's that called? Like a lifesaver thing for seniors have. It's like that life button for babies.
Yeah, and absolutely, as Natalie said, if sites are working on developing this, there's no point recreating the wheel. We're happy to share all of our resources and materials with sites that are looking to do something similar.
That in all the telehealth presentations we've done, I think the ability to help build relationships between the tertiary center and the remote center, that the visual element of it, the comfort that it provides to the local practitioners, I think I don't think that can be emphasized enough of just the relationship that it builds between the two centers. We've heard that over and over for sure. We did have one last question that came in just as we were wrapping up. Just wondering if you have explored using telehealth for medical rounds so that parents and remote practitioners can participate in rounds.
That's not something we've explored yet. I know that I've seen sites in the U.S. that do that, and certainly that may be something for the future, but it's not something we currently do.
But we do have some of our hospital with Covenant Health, I believe, they're doing something with videoing babies so that the parents can see their babies. Mm-hmm. So I can see how that would be, future direction sure for telehealth being a benefit, especially as families have babies in the NICU for a long period of time and need to go back and forth to home. It would be very advantageous for sure.
Yeah, so the program that just started at the Covenant site.
Oh, is it Covenant or Saskatoon?
No, at the Misericordia Hospital. Yeah. So they have a tablet. It's tablet based, and they have one that's in the NICU and one that's on the postpartum ward. So when mom is not able to mobilize immediately after the delivery, but the baby's been moved to the NICU, they can video conference, and that's through the Real Presence Desktop program that they're doing that. So I don't think they've used it on rounds yet, but I think there'd certainly be potential for that.
And in southern Alberta, they're working on a project doing rounds at one of the level 2 sites with one of the tertiary centers, and that's really up and coming. And I would think that'd probably be the middle to the end of 2019 that they'll be moving forward with that. They're just working on the connections and the equipment.
All right. Well, if anyone's interested in learning more about that, I certainly encourage them to reach out and connect with you guys. Your contact information is still up on the screen there. But with that, I think it's a good time to wrap up. I think we've exhausted the questions and the discussion here, so it's a good time to close this off. So thanks again for doing the presentation today, and congratulations again for the poster award that you won at the 2018 conference.
Thank you.
Yeah, thanks for the opportunity to present to the group.
All right. It was certainly our pleasure. We do our webinars every Wednesday at 11 a.m. Eastern time, and it's always great when you can watch live, as you do get your chance to inject your comments and ask your questions. But when you can't watch live, we do record these sessions and make them available after the fact on the Knowledge Exchange Network, which you can find at ken.childrenshealthcarecanada.ca. Our next webinar, this was our last webinar before we close off for the holidays over Christmas. And our next webinar will be on January 9th, and we will be welcoming back our partners from ChildBright. ChildBright is a large research initiative, a SPORE is what it's called, a strategy for patient-oriented research. And they've been producing some great work over the last couple of years that they've been in action. They're finally getting to the place where they're now starting to present some of their preliminary results. So lots of exciting work coming out of that network. And on January 9th, they'll be bringing the Strongest Families program, which is a program that I think we presented here before years ago, which is about giving remote and distant support to resources and mental health services to patients and families remotely. And they've now adapted this program to support children with complex neurodevelopmental needs as well. So we'll be hearing about how they've some of the changes that the Strongest Families program has made to accommodate that patient population. So that will be January 9th will be our next webinar after the break. So thanks again for joining us today. Hopefully everyone will enjoy some time off over the next few weeks, and we'll hope to see everyone back here in the new year. So thanks again. Bye.